So if you look at the 4 cardiovascular outcomes trial, and they have had a whole host of sort of patient population that were enrolled either with atherosclerotic cardiovascular disease or multiple risk factors, while we can argue whether it's a class effect or not, whether there's a MACE difference or mortality difference between this drug, that drug, at least the renal benefit and the heart failure benefit seems to be pretty consistent across all trials. That I think it's pretty reasonable to say that people who mimic the criteria for cardiovascular outcomes trial, that SGLT2 inhibitor should be given pretty much standard for disease modification. I mean, I don't think that we can say whether we can ignore side effects because there are benefits. So I think that these are sort of two separate constructs, and regardless of how good the benefits are, we still have to worry about the side effects and try to do whatever we can to minimize the side effects. Now, our patients want to live longer and healthier. So quality of life is a pretty important domain and pretty important goal of our management strategies. So any therapy that reduces the risk of mortality, hospitalization, but also in turns improve quality of life becomes sort of incrementally more attractive therapy. So if something improves survival but does not improve quality of life scores, well, survival is pretty important and you need to give it, and vice versa. If something improves quality of life, it's safe but doesn't improve mortality, that doesn't mean that you don't use that drug. So I think mortality, quality of life, and side effects are all sort of 3 independent domains, and you have to take them as such. Yeah, so I don't know the answer to your question whether empagliflozin data will show that or not, because remember, up until now, all the EMPA trials were done in patients with diabetes. So the first data that will come out in patients who don't have diabetes is actually with EMPA reduced. So nobody knows those data. Having said that, metformin and prevention of diabetes is something that physicians embrace. DAPA has presented those data, and they look interesting. I would say one trial, one drug, secondary endpoint, probably replication will be good. So let's see what Emperor shows. Yeah, but let's also not forget that the best way to prevent diabetes is eat right, lose weight, and exercise. So all of these things are in conjunction too, but not necessarily give the message that you don't need to do lifestyle modification and just take a pill to reduce your risk of diabetes. But I think that's one of the very interesting secondary analysis that we will all wait to see from the Emperor reduced trial. Well, I mean, I think inferior superior, I don't know about that. I mean, in general, all of these drugs tend to at least have heart failure and renal benefit, and some benefit is great. And usually sort of between the regulatory indication, guidelines, recommendation, and then getting on insurance formularies, and then hospital algorithms. These are sort of 3 or 4 different levers that eventually, when all pulled together, really increases the use of life-saving medication. So hopefully, yes. Well, I mean, I don't think that the issue is cardiologists getting involved in diabetes care. And what we learned from DAPA-HF is that the benefit of dapagliflozin is actually in both patients with and without diabetes. So I think it's a little bit of a mind shift. I think if you go to a cardiologist and say that you have to treat diabetes, I don't think there'll be a lot of takers, especially when it starts to discuss about the use of insulin and modulation of insulin and all that kind of stuff. So I think if you change the narrative, and if EMPA also shows benefit in non-diabetes patients, and we really solidify this position that the benefit is cardiovascular benefit that extends beyond diabetes, then I think for cardiovascular risk modulation, using these drugs and cardiologists getting involved is a better uh, proposition than to say to get involved in the care of diabetes per se.